So, big picture here, what is it going to look like when that patient comes in? So, what are some of the things that we're going to see? Well, one, that patient's going to have tachypnea. They're going to have tachycardia. The tachypnea is going to be secondary to some hypoxemia. Remember, we have a diffusion defect. We have pulmonary surfactant that's being washed out, that's increasing the surface tension, encouraging the alveoli to collapse on themselves, causing atelectasis. You have a widened AC gradient, and oxygen doesn't swim very well. So you're going to end up with some hypoxemia. So when you have hypoxemia, especially when that hypoxemia drops below 55, you get your peripheral chemoreceptors that jump in. So they are going to encourage an increased respiratory rate. You get that decreased in lung compliance. When you have a decrease in lung compliance and you use the same pressure, hear what I'm saying. You have a decrease in lung compliance and you use the same negative pressure to breathe, it will decrease the amount of volume that comes in. Well, if I decrease my volume, I have to increase my respiratory rate to maintain my minute ventilation. Stimulation of the J receptors and the baroreceptors secondary to that atelectasis. You have anxiety, you have perhaps some Cheyne-Stokes respiration. It's theorized that this is from a prolonged circulation time between the lungs and the central chemoreceptors. You have another cause of this whole issue could be central sleep apnea. You get, like I said, an increase in your heart rate, your tachycardia. We talked about the paroxysmal nocturnal dyspnea. Again, this is excessive fluid that is sitting at the dependent parts of your lungs. So they're at the lower portion of your lungs. So whenever I change from an upright position to now a lying or a recumbent position, now more fluid fills the posterior portion of, or the dorsal portion of your lungs. So that leads to an increase in venous return, which causes an increase in hydrostatic pressure, which then increases the risk for pulmonary edema. Orthopnea, we talked about that. We talked about the pulmonary shunting. Remember, this is circulation that's happening with no perfusion. So you've got no oxygen that's coming into the blood despite the blood moving across the pulmonary capillaries. You get hypoxemia, you get the cyanosis, you can have, you get the white or the pink frothy secretions. You can have an increase in tactile and vocal fremitus, leading to some fine crackles and or some cardiac wheezes. So what do we see here when we look at this? We've got a patient that is in this recumbent position. They're lying back and they're complaining that they cannot breathe when they are laying on their back, or they can only sleep like this for a couple of hours before they have to go sit in the recliner to then sleep. I've had this conversation with patients. I've had this conversation with family members. When you start to have those moments of I can't breathe lying down, I really start to think some sort of pulmonary edema. All of that fluid, whenever they're walking around, is sitting in those dependent areas. The bases of the lungs, it's sitting in the ankles of their legs, it's sitting in the calves, and then whenever they get into that recumbent position, that fluid moves back into the vasculature. That fluid moves back into the vasculature and starts to circulate. Well, when that fluid that's in the ankles and the calves goes back into the vasculature, it's going to move into that right side of the heart. From the right side of the heart, it's going to circulate around, and you get this increase in hydrostatic pressure. When you get that increase of hydrostatic pressure to the point that it's greater than the oncotic pressure, you end up with pulmonary edema. So this is a respiratory therapist doing an assessment on this patient. A lot of times you see, or I've seen it, where you have patients that are on albuterol for a wheeze, right? But the air moving across the fluid can cause a high-pitched sound, causing a cardiac wheeze. So sometimes I've heard it said like a wheeze is a wheeze and it needs albuterol. Well, that's not the case. We have to make sure that we're assessing our patients thoroughly and appropriately so that we can get them the right intervention. Now, there are times when patients can say, you know what, I understand that it doesn't open up my airways and it doesn't change anything inside my lung cavity, but I feel better. If the patient feels better with a breathing treatment, then it's our job to make that patient feel and breathe more comfortably. That is a subjective assessment, and I cannot say that that patient does not feel better after their breathing treatment. So we do our best to educate. We do our best to inform our patients. Ultimately, they tell us what's going on with their body, and we will take care of them the way that they understand what feels best. And we can encourage. We can talk to them. We can talk to them about other interventions, what we're going to talk about here shortly. But ultimately, if they give us it makes me feel a little bit better, then that's reason enough for us to do what we need to do to help somebody breathe a little bit easier today. Impacts of the pulmonary function testing. Remember, this is a restrictive disease. This is a restrictive disease. So all of your capacities, those are all going to be decreased. Your capacities are going to be decreased. This is a diffusion problem. So your DLCO is going to be decreased as well. And then when it comes to the vital capacity findings or the forced expiratory volumes and the flow findings, you're going to get your forced vital capacity that's going to be decreased. Your FEV1 is going to be normal, and then your FEV1 to FVC will be increased. ABGs, when we look at our ABGs, depending on how bad the patient is doing or how bad their pulmonary edema is, if it's mild, then they're going to end up with acute alveolar hyperventilation. They're going to end up with some hypoxemia. They're going to breathe more. They're going to beat more. That's what we would expect. When the pulmonary edema gets to the point that it's severe, now this patient is running a marathon, and at some point they're going to peter out. When they peter out, that's when they're going to go into acute ventilatory failure. Our job is to make sure that we can recognize when that patient's in acute alveolar hyperventilation, because another name for that is impending ventilatory failure. We just have to recognize when they're moving from impending to vent failure. Ideally, we need to intervene before they go into acute ventilatory failure, and that's where we use our eyes, we use our assessment skills, we use the therapies that we have around us to take care of these patients. When we look at the hemodynamics, everything on the right side of the heart is going to be increased. Everything on the right side of the heart is going to be increased. So from your pulmonary capillary wedge pressure, your SVR, and your right ventricular stroke work index, and your stroke volume index, all of these are going to be increased. The right side of the heart is going to be increased. The left side of the heart is either going to be decreased or normal. Decreased or normal. So Respiratory Coach has a really good talk about hemodynamics. And what you have to do with hemodynamics is you have to find where the problem is. Well, if the problem's in the lungs, then everything behind the lungs is going to be increased. There's going to be a traffic jam, and blood flow is not going to move as readily. Everything beyond it, traffic starts to lighten up, and you have the opportunity for either a decreased flow because you're not getting as much volume across, or normal flow because you're past the obstruction. When we look at our labs, we need to look at the basic metabolic panel. When we look at the potassium, sodium, and chloride, these are all going to be decreased if they're on diuretics. Diuretics, remember, are a water pill. They help us get rid of fluids. For now, that's the level of understanding that I want you guys to have with diuretics. At some point, we will talk about the different classifications of diuretics, some that are potassium sparing, some that are potassium wasting, loop diuretics, etc. We'll talk about all of the different types in future lectures. And then we have what is called the BNP, not to be confused with the BMP. The BNP, or the brain nucleic peptide, this will actually be increased. So when we have our sodium, potassium, and chloride, these will be decreased with patients that are on diuretics. And we have the BNP, which will be increased. That is the brain nucleic peptide. So BNP is measured in PG per ml. And when we look at no heart failure, this is going to be less than 100. With heart failure might be present, this is going to be 100 to 300. And then you have mild, moderate, and severe. Mild is greater than 300, moderate is greater than 600, greater than 900 is severe heart failure. So anytime that you look at your BNP and it's greater than 900, we've got a lot of work to do. Now, if it's greater than 300, we've got some work to do. Even if it's less than 300, it's still an indicator that we have some work to do. So when we look at x-rays, what we're looking at is, does this patient have cardiomegaly? Again, cardiomegaly is an enlargement of the heart. The way that we kind of do this in a quick estimate is the heart, does it take up more than half of the thorax in that chest x-ray? So if it does, then we classify that as cardiomegaly. Does that patient have left ventricular hypertrophy? So do we have an enlargement of this left ventricle? You can see that right here. Then we look at, does this patient have bilateral fluffy opacities? This will look like bat wings or butterfly wings centrally in the chest. This comes from the dilated pulmonary arteries, and it can lead to some curly A, B, or C lines. And if these aren't taken care of, it can lead to some pleural effusions. Again, the lymphatics can only keep up with so much. If it's not able to keep up, it's going to spill over somewhere, and that spillage is going to be the pleural space.